can you please take your seat in front of the stage? Bear with me for another hour. I'm honored to be your moderator for another hour. Moving on to our plenary session 4. Okay, sure, for sure. Okay. Morning, ladies and gentlemen. I'm Dr. Hena Latif, your moderator for this session, and we are privileged to have a truly eminent panel of chairs presiding over this session, which is plenary session 4. Before we begin, I would like to welcome our distinguished panel of chairs who will be presiding over this session. I would like to call upon the stage Professor Amir Ghafoor Khan, Head of Gastroenterology and Hepatology at Lady Reading Hospital, Peshawar, a globally recognized educator and a clinician with fellowship from across the UK, Ireland, and US. He is SVP International Affairs, Pakistan Society of Internal Medicine. Please put a big hand of applause, Professor Amir Ghafoor. Our next chairperson for this session, Professor Dr. Qazi Masroor Ali, Head of Medicine and Cardiology at Bahawalpur Victoria Hospital, Bahawalpur, and a leader in health professional education, Professor Qazi Masroor. Our next panelist, Professor Dr. Sajid Ubaidullah, former Professor of Medicine at King Edward Medical University, cornerstone of Pakistan Society of Internal Medicine. As treasurer of PSIM, he plays a key role in managing the society's financial and administrative affairs. Welcome, Professor Dr. Sajid Ubaidullah on the stage. Our next panelist, chairperson, Professor Dr. Shabnam Naveed, Head of Medicine at Jinnah Postgraduate Medical Center, Karachi, and President of PSIM Karachi Chapter. Professor Dr. Shabnam Naveed Kurejo. She will be joining us soon. Oh, okay. Thank you, ma'am. Our session today focuses on critical updates in vascular and hepatic medicine. Venous thromboembolism remains a significant challenge in clinical practice, requiring a delicate balance of vigilance and evidence-based intervention. It is my pleasure to introduce our first speaker, joining us from Singapore, Professor Heng Joo. Professor Heng Joo is Senior Consultant and Head of Department of Hematology, Singapore General Hospital and National Cancer Center, Singapore. He is Clinical Professor with the Duke National University of Singapore School of Medicine. He will be sharing his expertise on venous thromboembolism, prevention and management updates. Professor Heng Joo, the stage is all yours.
Thank you, Dr. Hina, for the introduction. A very good morning to all of you. I think it's certainly a pleasure for me to be here in the beautiful city of Lahore and to be part of the Pakistan Society of Internal Medicine Congress. I think your program has been very impressive, and I'm delighted to be in the presence of very esteemed people in internal medicine. I'm from the Singapore General Hospital. In the next 20 minutes or so, I will be providing you with an update on venous thromboembolism prevention as well as treatment. And what I did was, of course, to skim through the literature to see what are the available evidence that has been published over the course of the past 1 year. So this will be the brief outline of what I'll be covering. As Dr. Hina has mentioned, venous thromboembolism remains as a significant condition that afflicts a large population of the world population. In Pakistan, currently, we do not have large population studies, but from the published literature, we do know that venous thromboembolism happens at about 2 to 12% of admitted patients who are hospitalized in Singapore. On a worldwide basis, it is stated that 1 in every 12 people will experience a venous thromboembolism during his or her lifetime. And unfortunately, although there has been progress that has been made in medicine in various fields, we find that the incidence of venous thromboembolism has not declined over the years despite advances in medicine. And there is also association, of course, with various risk factors. And of course, there's a rising prevalence of major venous thromboembolism. Risk factors which has been identified as aging, obesity, cancer, as well as surgery, and they have been combined, of course, to increase the risk of venous thromboembolism among the population. For those people who have had a venous thromboembolic event, I think the long-term complications includes post-thrombotic syndrome, and of course the possibility of chronic thromboembolic pulmonary hypertension, which gives rise to significant comorbidities, including shortness of breath, reduction in effort tolerance, and an inability to work. So it's stated that VT is associated to a 2 to 3-fold increase in the risk of work-related compensation because of the comorbidities that is associated with this. And obesity, which I've earlier on cited, is one of the major risk factors for for venous thromboembolism, unfortunately, of course, is increasingly prevalent in various parts of the world, and up to about 10 to 30% of venous thromboembolism event can be attributed to overweight or obese patients. As much as we understand about the mechanism of venous thromboembolism, I think all of us would recognize Verhoef's triad as being important in the development of venous thrombosis, and that is the constellation of venous stasis, vascular intimal injury, as well as a hypercoagulable state. I think more is being paid into biomarkers that may contribute to the possibility of a hypercoagulable state in patients. So I think for all of us clinicians, internal medicine specialists, hematologists and whatnot, the goals of care of VTE's management, of course, is number one, where possible, to try to prevent the first venous thromboembolism in patients who are susceptible. And in those patients who develop a venous thromboembolism event, it is our goal to try to assess patients to see what is the risk of developing a second event or a third event, and put them on what we call secondary prophylaxis, such that it can reduce the possibility of sudden death as well as longer-term complications associated with venous thromboembolism. But the current standard of care for treatment of venous thromboembolism remains as that of anticoagulation therapy. And with anticoagulation therapy comes with the risk of bleeding complications. So it's also our goal to reduce long-term complications of venous thromboembolism, which is post-thrombotic syndrome, and that occurs in about 50% of people with venous thromboembolism. The more important thing is chronic thromboembolic pulmonary hypertension, or what we call CTEPH, and CTEPH happens in about 3% of patients who develop pulmonary embolism in patients. So over the course of the past 1 year, there have been various updates to the guidelines. I think in the course of the 1 year or so, in the pediatric population for which the use of DOACs is now the prevalent anticoagulation therapy for adult patients, the pediatric clinical studies have been completed in most instances, and it's now recommended that DOACs, of which dabigatran, apixaban, and rivaroxaban has published evidence, is now recommended as a standard of care over low molecular weight heparin and warfarin for the treatment of pediatric populations as appropriate. And this is from the ASH as well as ISTH guidelines. Very commonly, of course, venous thromboembolism is associated with cancers, so the use of DOACs is now the primary treatment alongside low molecular weight heparin for CAT, and this is in the NCCN guidelines. The other thing, of course, is that there's always a concern about bleeding in patients with cancers because of the prevalence of thrombocytopenia in such group of patients. Now, the NCCN guidelines has been a bit more explicit in saying that prophylactic anticoagulation therapy may be withheld for patients if your platelet count is less than 50,000 to reduce the risk of bleeding complications. We also know that in perioperative VTE prophylaxis, the recommendation now, instead of being standardized across the board, of course, is to use individualized VTE assessments with the use of risk assessment tools such as the Caprini score, which is well validated in patients undergoing surgery. In the advances in diagnostic VTE testing, I think that the age-old diagnostic tool that was used was D-dimers in patients in the ambulatory care setting as a negative predictive tool. This is to help clinicians reduce the utilization of CT scans as well as Doppler ultrasound studies in patients whereby the D-dimers are actually very low, such that it improves the utilization of resources. But we do know that D-dimers are poor in terms of specificity because D-dimers are raised in the elderly population in patients with ongoing inflammation as well as malignancies and those undergoing surgery. There have been some progress in the field of other alternative biomarkers, like, for example, E-selectin and P-selectin, which are adhesion molecules in inflammation and thrombus formation. And the use of multiple biomarkers as such can be incorporated into VTE risk prediction models for cancers, such as factor 8, time to peak thrombin generation, fibrinogen levels, as well as the mean platelet volumes. And of course, interestingly, there have been a number of published studies that uses proteomics, which is the study of proteins, to help as a platform to help identify biomarkers that may be utilized for the prediction of venous thromboembolism. Another advance in VTE diagnosis is the use or the availability of what is known as advanced CT technique that's called photon counting CT scans. And what in photon counting CT scan does is that the X-ray photons is directly converted into energies, and the new CT scan machines have what is known as photon counter detectors. They are able to detect the energy that is emitted via the X-rays. And what it does in comparison to the standard dual energy energy integrating detectors, of course, is that there is improved spatial resolution as well as reduction of the beam artifacts, enabling the visualization of finer anatomical details, such as the architecture of the lung as well as the parenchyma. And what it does, of course, is that it produces superior iodine signals in vessels compared to conventional CT scan, allowing for better discrimination of small pulmonary vessel opacification and reduces motion artifacts. More importantly, of course, is that the use of photon counting CT scans may reduce the radiation dose by about 50% compared to conventional CT scan, while improving image quality as well as a reduction of contrast media. And the reduction of contrast media, of course, is something that's pretty important as far as patients with renal impairment is concerned, because you can then make use of the possibility of photon counting CT scans for patients with renal impairment. The top two images, A and B, shows you what is the image that is obtained from the photon counting CT scans, whereas the bottom two images are from dual energy EID CT scans. And although it may not be clear here, in the top two images, you can find that the thrombus that is demonstrated there is much more distinct, and there are much less motion artifacts, making it a whole lot easier for the radiologist to call this as a pulmonary embolism. So I think that's the benefit of photon counting CT scans, so it will improve the diagnosis as well as the accuracy of diagnosis of pulmonary embolism. Now, artificial intelligence has been talked about in venous thromboembolism, or rather in the medical field, and certainly is something that people look at in the venous thromboembolism diagnosis field. And take, for example, the use of AI in the diagnosis of VTE. In the top cartoon there, you can see that without pulmonary embolism, one of the possible protocols in hospital is that if a patient is suspected to have venous thromboembolism, he goes for the CT scan, he completes the CT scan, he may go back to the ward, or he may even be discharged from the hospital, and he waits for the results while the radiologist looks at the CT scans, and probably in about half a day or a day later, he makes a decision as to whether the patient has pulmonary embolism. If there is pulmonary embolism, the patient gets called, or the ward gets called, and treatment gets instituted. So in a sense, of course, is that there is somewhat of a delay in the diagnosis, whereas if you use artificial intelligence, what it hopes to do, of course, is to be able to pick up the possibility of pulmonary embolism in such group of patients within a few minutes, and then, of course, treatment can be first instituted for the patient. But as it stands currently, of course, the current protocol still requires a radiologist to eventually call whether there is a pulmonary embolism or not. And of course, then if there is a pulmonary embolism, to continue on the treatment. If there's no pulmonary embolism, the treatment that has been given for the patient, which is usually just one dose of anticoagulation, may be stopped for the patient. There have been a number of protocols that have been used for this AI models. The most studied is the so-called ADOC model, and there's another model that's called the CINA-IPE models. And the negative predictive value of AI in such instances in aiding the diagnosis of pulmonary embolism for the radiologist has been pretty high, close to about 100%. But one of the downside of this, of course, is the still relatively high positive predictive, still relatively low positive predictive value, which means that there is a likelihood of false positive results that are going to be called for the patients. So it still requires human oversight and adjuncts, but it may still improve the speed at which we pick up patients to avoid the delay in the diagnosis of pulmonary embolism. So I've mentioned some of the hurdles that we have in the AI for VTE management, especially in the radiology field. It's the validation of consistent protocols, false positives that can lead to radiologists fatigue because they have to review that, and of course the need for evidence that improves care compared to conventional models, and lastly, cost and funding availability. Now, better risk assessment models have also in place with the use of artificial intelligence for predicting VTE. And in the course of the past 1 or 2 years, there have been quite a number of studies that looks at various models like machine learning and so on, linear regression models and so on, to try to improve the pickup of the prediction of VTE and with varying success rates. But what is important, of course, is that it comes as being an important development because the current validation tools that we use for the prediction of venous thromboembolism, if you take the example of cancer-associated thrombosis, is pretty low. If you look at the C statistics for the, some of the more commonly used scores like the Corona score, they perform reasonably quite poorly. So what we hope, of course, is that with the refinement of the assessment tools, we can now use a two-step process, incorporating a scoring system, like for example, the TRIPCAS in patients undergoing with fractures, and also personalized assessment utilizing AIs and machine learning such that it can refine the model such that C statistics can be improved for patients. Now, very quickly, of course, running through new developments, of course, in the pharmacotherapy fields. There's a comparison, of course, between, the question has always been asked, of the DOACs that we use, which is the better DOAC? Rivaroxaban, apixaban, or dabigatran? And now there's been some studies have been done looking at rivaroxaban versus apixaban for acute venous thromboembolism. And some study of that is that apixaban has lesser clinical relevant bleeding as opposed to rivaroxaban. And this is a head-to-head comparison study as opposed to previous study that were not head-to-head comparisons. In the field of cancer-associated thrombosis, apixaban has been looked at and in various fields, and this is a meta-analysis of which I don't have enough time to go through, but suffice to say that apixaban has emerged as the preferred anticoagulation therapy for patients with active cancer simply because it has got less risk of bleeding as well as an increase in efficacy as compared to the other DOACs, and more importantly, compared to low molecular heparin and warfarin. But is there still a role for low molecular heparin? And the short answer, of course, is yes, there is. It is used in patients at risk of oral drug malabsorption. It is at risk for use of patients with high risk of bleeding, especially those with thrombocytopenia, liver insufficiency, as well as gastrointestinal and GITE, as well as GUT cancers. And in occasions whereby there are drug-to-drug interactions, low molecular weight heparin is still preferred. The next thing, of course, is new targets for anticoagulation therapy, for which the latest development is in what is targeting factor 11. As you can see from the cartoon here, factor 11 is part of the contact activation of the intrinsic pathway of anticoagulation. It doesn't take part directly in the final formation of the blood clots, for which the traditional DOACs targets thrombin as well as anti-10A. So the sum total, of course, is that if you target anti-10A as an anticoagulant, you are likely to get some elements of anticoagulation effect on it, while with limited impact on bleeding. And this has been shown in studies for which there are now a number of anti-10A inhibitors, one of which is abelacimab, which is given as an IV infusion for patients. And I think the benefit of that is that it can be given as an infusion just as a single dose for patients undergoing prophylaxis, or in patients as a once-a-month treatment for atrial fibrillation. In the interest of time, I think I'm going to stop here with this brief summary of what are the latest updates for venous thromboembolism management as well as prevention in the field. Thank you very much for your attention.
Thank you so much, Professor Heng Joo, for highlighting the evolving landscape of venous thromboembolism management.